So today I'll be taking a pancreas with you, okay? So as far as the pancreas is concerned, it is another intra-abdominal organ which we will be discussing today, okay? So as far as pancreas is concerned, I'll be just going through the anatomical points, the relations, the surgical anatomy, the medical aspects related to pancreas. Now, there are certain important things which you have to remember. The first point is that pancreas in itself is one of the organs about which the abdominal surgeons are a bit terrified. Very sincerely, I am telling you this thing. This is a question, a topic, which is quite expected for examinations as well. Now, first of all, as far as this pancreas is concerned, you have to remember that it is one organ which is elongated. Okay? It is elongated. It spans the breadth of the abdomen from right to left or left to right. That's first thing. Number second, it derives its name. Pan means all, Krias means flesh. It is a soft, flesh and lobulated organ, and lying between the vertical levels L1 and L2. That should be very clear to you. Now, it has got a relevance, which I will be taking up later. Why this thing? Number one. Number second thing is that this pancreas, as an intra-abdominal organ, I mentioned the softness, I mentioned the fleshy character. Now, it is 15 to 20 centimeters in length. Okay? And this pancreas is divisible into various anatomical regions. As you can see in the figure over here, it is the head, the neck, the body, and the tail. So this is the head proper, this is the neck, this is the body, and this is the tail. Now, as far as a very special part of the pancreas is concerned, there is just, in relation to the head, going towards the neck, there is a slight different region which we give the name over here as an unsnake process. So the head, the unsnake process, the neck, the body, and the tail. So starting from this would be which side? The right side, and this would be the left side. The head, neck, the constricted part is the neck, body, and the tail. So these are the parts while going from right to left. That's it. Now, as far as this pancreas is concerned, important fact is that this pancreas, from right to left, on the right side, the head of the pancreas is related to the concavity, the C of the duodenum. Very important. And the tail is related to the spleen. Okay? So, two important organs which lie in relation to the right and the left side of the pancreas, or the two ends, the head end abuts or lies within the C or the concavity of the duodenum. And that's very important. Why? That also I will be telling you later. And the tail lies in relation to the spleen. Very important. So remember these two things. Okay? That is one part. So after this thing, we go to the next slide. And the next slide shows, as you can see over here, this is the next slide, and it shows the relations of these parts of the pancreas. Okay? So as far as the head, neck, body, and tail of the pancreas are concerned, it is a question quite frequently asked, and it is of much importance. Why? Again, in the class. So as far as the head of the, I was just telling you, so this is the head of the pancreas, and it lies within the C concavity of the duodenum. And as far as this, the tail of the pancreas, it just goes in relation to the hilum of the spleen. Now, first of all, taking the head of the pancreas into account. As far as the head of the pancreas is concerned, on a, I would say, macroscopic level, we have two surfaces, the anterior surface and the posterior surface. Okay? So the anterior surface of the head of the pancreas, there are three borders. One would be the head will be in the superior border, the inferior border, and the right lateral border, the head of the pancreas. But the surfaces grossly would be anterior and posterior. So there will be certain structures which lie anterior to the head of the pancreas. There will be certain structures which lie posterior to the head of the pancreas. So what lies anterior to the head of the pancreas? Three things. Three parts of the intestine, small and large. The duodenum, the transverse colon, and the ileum. They lie in relation to the, as you can see over here. So we have got the duodenum, the transverse colon, along with the transverse mesencolon, which lie in relation to the anterior part of the anterior surface of the pancreas. Now, as far as the posterior relations are concerned, posterior to the head of the pancreas lies the right crus of the diaphragm. What? The right renal vessels. What? And inferior vena cava. Because once we go to the posterior abdominal wall, the aorta lies towards, a bit towards the left, and I mean to the celiac trunk and the superior mesenteric vessels, and I mean to say other branches, they lie a bit towards the right. That's important. Okay. So as far as the head of the pancreas is concerned, it lies to the right. So we will be having the right kidney, the right renal vessels, and the inferior vena cava, forming the posterior relation of the head of the pancreas posterior. Now, after that comes the neck. The neck of the pancreas is a slightly constricted part, as I showed you in the last slide. So this part is the neck of the pancreas. So this part is the neck of the pancreas. And one important thing to remember is that the neck of the pancreas, posteriorly, there is the splenic vein and the superior mesenteric vein, which join together at level of the neck of the pancreas to form the portal vein. Very important. So behind the neck of the pancreas lies the portal vein, and anteriorly lies the peritoneum covering the lesser sac. Because behind the stomach we have got the lesser sac, so anterior relation of the neck and the part of the body of the pancreas which will be coming up will be the peritoneum overlying the lesser sac, but posteriorly to the neck of the pancreas will be the portal vein. And the portal vein is formed at the level of L2 by the union of two veins, the superior mesenteric vein and the splenic vein. So that is very important as far as the relations, posterior relation of neck of pancreas is concerned. Then once we move towards the left side, okay, we move towards the left side, and we have again the anterior surface, the posterior surface, and the anterior surface of the pancreas again lies in relation to the peritoneum covering the lesser sac. Now posteriorly, what lies posterior to the body of the pancreas? Because after head, neck, we have the body. So posteriorly what lies is the left kidney, the left renal vessels, okay, the left crest of the diaphragm, and a part of the abdominal aorta. Because now we are moving towards the left side. So you can imagine, towards the head there was something else, towards the body there is something else. So that is important. Now, after the body, head, neck, body, comes the tail of the pancreas. And this is the tail of the pancreas. I will show you. Just a second. So after, now over here, this is the tail of the pancreas. So this is the tail of the pancreas, and it goes in relation to the spleen. It goes in relation to the hilum of the spleen. And there's a very important ligament, lieno-renal ligament. Lieno-renal ligament. The tail of the pancreas lies within the lieno-renal ligament, and that goes towards the hilum of the spleen. So very important. these might be sounding to you very basic facts, but they are very important relations and you have to remember them. Why? Because I will be telling you the clinical significance of these things ahead. And that's why I mentioned you the tail of the pancreas is very important as far as its relation to the spleen is concerned. So this is something about the cross relations of the head, neck, body and the tail of the pancreas, and you have to be well versed with this thing as far as the theory is concerned, as well as the diagrammatic aspect, because sometimes we put a question to you just with the help of a neat label diagram, show the relations of the different parts of the pancreas. This is the question we give, maybe 10 marks, maybe 5 marks, so you should be very much capable of just drawing a diagram showing these important structures which I just enumerated. So that is one part. Now after that we have got this pancreas, and as far as the neck of the pancreas is concerned and the formation of the portal vein is concerned, is very important because we'll be taking a portal vein and portosystemic anastomosis ahead. So you can see that this is the vein coming from the left, the splenic vein, and this is the splenic mesenteric vein, and they join at the level of neck of the pancreas and they form the portal vein. So this is something about the portal vein and the relations of the pancreas. Now, as far as the relations are concerned, now this diagram depicts it what I just enumerated to you. So this is a sort of a diagram which you can take help of or from the other textbooks which you like. So over here you can see the right kidney, the right suprarenal, the right colic flexure, okay, the splenic mesenteric artery I told you. Then I told you something about the left colonic flexure, the left suprarenal, the left kidney, and these are some of the relations. You have to draw a precise diagram denoting these relations. Now, as far as this pancreas is concerned, the pancreas has a good vascular supply, and this vascular supply of the pancreas is by virtue of certain important vessels. And what are the blood supply of the pancreas? Which vessels are important? Now, as far as, because we have not gone to the blood supply of the gastrointestinal tract, you will be coming across celiac trunk, you will be coming across superior mesenteric artery and inferior mesenteric artery ahead. But over here, let me just concisely put it in this manner, that there is one vessel which is given the name as splenic artery, and splenic artery is a branch of celiac trunk. Okay? So splenic artery, from the splenic artery, certain branches arise along the course of the pancreas. Okay? They give blood supply to the pancreas. And to know two important branches especially, arteria pancreatica magna. Sometimes there is this inconsistent branch which is bigger than the other branches, and we give it the name as arteria pancreatica magna. Arteria means artery, pancreatica means refers to pancreas, and magna means big. So a bigger branch. Okay. Then we have one important artery at the extreme and at the terminal end, and that is the name arteria cauda pancreatica. And arteria means artery, cauda means tail, pancreas means pancreas. So you can see over here, well defined over here, arteria cauda pancreatica. A well defined branch, arteria pancreatica magna, and you can see it is bigger. Then this is the splenic artery, and you can see multiple branches from splenic artery just giving branches to the pancreas. So splenic artery. Now, as far as the other vessel is concerned, we have this important vessel which is given the name as superior pancreatico-duodenal artery, and this superior pancreatico-duodenal artery just arises on the superior border just near the head of the pancreas, and exactly opposite to it is on the inferior surface, inferior border, we have got the inferior pancreatico-duodenal artery. So superiorly, the superior pancreatico-duodenal artery, inferiorly, the inferior pancreatico-duodenal artery, and along the right margin, the anastomosis between the superior and the inferior pancreatico-duodenal artery. As simple as that. So superior pancreatico-duodenal artery, superiorly, inferior pancreatico-duodenal artery, inferiorly, and then along the right margin, we have got these two vessels anastomosing with each other. Where from these vessels arise, I will tell you once we deal the blood supply of the gastrointestinal tract in detail. That I will tell you. So here we have got these things. We supply the pancreas, okay? And venous drainage, superior mesenteric vein, splenic vein, they form the portal vein. Portal vein is one important vein which carries maximum brunt of the venous blood supply from the gastrointestinal tract. Importance I will tell you once we deal the portal venous system in detail. So that is something about the blood supply of the pancreas. Now, as far as the lymphatics of the pancreas are concerned, the lymph nodes, there are many groups of lymph nodes which surround the pancreas, and as you can see over here, we have got the superior pancreatic nodes, we have got the inferior pancreatic nodes, we have got the superior mesenteric aortic nodes, the pyloric nodes, the left gastric nodes, the celiac nodes, and the pancreatic duodenal nodes. So these are the lymphatic territories, a group of lymph nodes to which the pancreatic lymphatics go. So you have to remember these things, and the exact location inferiorly, and exact location superiorly, then the pancreatic duodenal, the pyloric, the left gastric, the celiac, you already know. Okay, so these are some of the important groups of lymph nodes seen in relation to the pancreas. Now, after that, what is important as far as this pancreas is concerned? Now, pancreas is one gland which is a mixed gland. It is having both an endocrine part and an exocrine part. I will not go to the physiology of pancreas, the pancreatic juice, the insulin, the glucagon, and all those things that you know in studying physiology. Okay, there are capable people over there who will teach you those aspects. But over here you have to remember that there's one important thing. One is the pancreatic ductal system. Because now this is a gland, it's a mixed gland, both endocrine and exocrine. So it should have a ductal system. And pancreas is blessed by two ducts. One is the main pancreatic duct, okay, which is given the name as duct of Wilson, and another is the exterior pancreatic duct, which is given the name as duct of Santorini. Okay, so this is the main pancreatic duct. As you can see, this is the main pancreatic duct, okay, and this is the main pancreatic duct. Now, what happens? The main pancreatic duct starts from the left side, exactly from the tail, and you can see small ductules joining at an angle. Okay, and they give this pattern to the pancreas, which is given the name as herringbone pattern. So herringbone pattern is nothing. It is that once the small ductules open into larger ducts at an angle. So over the whole course of pancreas, this is the arrangement, which is given the name as herringbone pattern. So the main pancreatic duct. Okay. Now important is the ductal, the biliary system. What happens? Eventually these have to drain into some part of the gastrointestinal tract. Okay, and why does this end? This ductal system ends in the duodenum at two places. One is the major duodenal papilla, and another is the minor duodenal papilla. So the main pancreatic duct, which is over here, it joins the common bile duct. What? Common bile duct. And forms the hepatopancreatic ampulla. Okay? So both these ducts join and form a sort of a dilatation. Hepatopancreatic ampulla. Pancreas because of this thing, hepato because of the bile duct. And then along with that bile duct, they just drain into the duodenum at the opening. The opening in the duodenum, while these just drain the secretions, are given the name as major duodenal papilla. Whereas the other exterior pancreatic duct that drains into the minor duodenal papilla. These are two separate openings in the duodenum. Okay, one is 8 to 10 centimeters from the pylorus, and another is 6 to 8 centimeters from the pylorus. So the openings of the major and the minor duodenal papilla are there, which represent the openings of the main pancreatic duct and the minor pancreatic duct into the duodenum. So this is how the physiological secretions are poured into the would say, gastrointestinal tract. Now, this is one aspect of the pancreas. So by now we have come to know about, I would say, the anatomy of the pancreas in a brief nutshell. Now, why does this anatomy, the knowledge of anatomy or surgical anatomy, help you? Now, as far as this pancreas is concerned, you will be just seeing that we have gone through various important things. Now, first of all, the relations. What is the importance of knowing the relations of the pancreas? Now, this is the head of the pancreas and it lies within the concavity of the duodenum. Once the head of the pancreas lies in relation to the concavity of the duodenum, say for example, a patient has got a pancreatic mass and I am just telling you in relation to the head of the pancreas. So other patients have tumor head. I am not talking about the neck, the body and the tail. About this area. What will it compress? Duodenum. So if a patient has got a big, large, advanced cancer head of pancreas, what will a patient present with? Vomiting. Because food will not go down. So at a late stage, I am not talking at an early stage, so there will be obstruction. So important, not the tail. I am not referring to the tail, I am not referring to the body, I am not referring to the neck, I am referring to the head. So a patient with cancer head of the pancreas can present vomiting. So sometimes the patient vomits. He comes to you, maybe he has taken some not good hygienic food. Vomiting can be due to that as well. But see, the range. Vomiting can be due to cancer head of the pancreas. This is why the knowledge of a doctor comes into account. You give antiemetic, that's fine. He does not improve. He comes after 2 days, he comes after a week, again repeated vomiting. Why? Why should a young patient have repeated vomiting despite having not changed the food and all those things, taken medications? Medication will not help in this case. So, the knowing the importance of the relation of the head of the pancreas to the C of the duodenum. I just mentioned very simply in the first sentence. Does it carry weight? Yes, it carries a lot of weight. So, the relation of the C of the duodenum to the head of the pancreas. You need not have a specialized PET scan, MRI scan to do this. The relation of the head of the pancreas to the concavity of the duodenum, that's all, if you are a good condition physician. Okay? So that is, the patient will definitely present with obstructive jaundice along with vomiting, and that's one part. So knowing the relation. Now I told you at the onset a simple statement that surgeons are terrified of pancreas. They are good with gallbladder, good with appendix. There's a lot of money there, easy money, isn't it? But pancreas, what do we do about it? Very important thing about the pancreas is that pancreas, as far as physiology is concerned, it releases pancreatic enzymes, and these are lytic enzymes. They destroy all the things in their vicinity. Pancreas is one intra-abdominal organ which you should be very, very much afraid of. Why? Sometimes a patient presents to the pain. Now, coming back to one point, I told you that the pancreas traverses from right to left or right to left. It's an elongated organ. Simply a statement here. But what is the importance? A patient comes to you to an OPD or a clinic, just like this, agonizing pain, and he just moves. He is not telling me anything. He is not moving towards the right hypochondrium only. He is not moving towards the right left. He just comes. He is, breathless. He is in a state of tiredness, fatigue, and deep pain. Got it? And he just moves. He does not tell you. He just, and then. So pain, radiating right from right to left, left to right, and to the back. Pancreatic pain is very severe. Number one. Number 7, it is in the form of a band, a wave-like across the abdomen. That is knowing the importance of the right to left or right to left to right. So band-like, wave-like, because pancreas inflammation is there, maybe pancreatitis, which is the inflammation of the pancreas, associated with the release of these enzymes, and what it causes a terrible pain to the whole of the abdomen in a bad way, and to the back. That's very important. Sometimes the patient presents with acute, severe back pain, and that pain is just because of pancreatitis, because of, involvement over there. So that is the pain of the pancreatitis, knowing the anatomy of the pancreas. Okay, so this would be the typical way a pancreatic pain, pancreatitis, or inflammation of the pancreatitis would produce. So severe agonizing pain in a bad Mbbs form in the whole of the abdomen anteriorly as well as to the back, classic of pancreatitis. That's one part. Now, why should this pancreatitis occur? We just studied the ducts. Say there's a stone in the ductal system, the main pancreatic duct or the axillary pancreatic duct. What will happen to the ductal secretions? Will they go out? Will they drain into the duodenum? No. What will happen? There will be a reverse flow. There will be congestion, passive congestion. And what happens? There will be release of pancreatic enzymes. And what happens? These pancreatic enzymes are proteolytic. And you know biochemistry more than me. Okay? And what they do? They just go and they just act like acid. What does a battery acid do to the surrounding things you have seen? Okay? The same manner. The same manner in case of severe pancreatic inflammation, the pancreas digests itself and pancreas digests the other surrounding structures as well. Very important. Acute pancreatitis is one clinical concern which a patient should report immediately and which a doctor should not miss. Very important. Take acute severe abdominal pain as pancreatitis very, very seriously because it can progress to necrotizing pancreatitis. All the tissue around the pancreas will undergo necrosis along with the pancreas. And what's important for you, what we usually do, that a patient comes to you and invariably you have to do an abdominal examination, isn't it? And what do we do in the abdominal examination? We just, isn't it? What we do? Palpate or percuss. Never in case of a patient with acute pancreatitis, place your hand on the abdomen and just do too much of an intervention with your hands, because the time you are placing your hands, you are inciting pancreatic inflammation. By mere touching of your hands, there will be a release of more proteolytic enzymes and it can precipitate acute pancreatitis. That's very important. So invariably, you should not fiddle much with the patient's abdomen in case the patient presents with and you have a clinical suspicion that this patient has. So what you are doing more harm to the patient rather than benefiting him or her once you are palpating the abdomen of a patient with acute pancreatitis, because that causes release of these little enzymes and you aggravate and exacerbate the acute pancreatic condition. Now, what is important about these pancreatitis is that there can be stones, calculi, within the pancreatic ducts, the main pancreatic duct and the axillary pancreatic duct, and that can cause acute pancreatitis. And one of the most common causes of pancreatitis is chronic alcoholism. Alcohol is one thing which precipitates pancreatitis, especially long-standing alcohol intake can induce chronic pancreatitis. That's very important. So these are the important facts which you come to know after knowing the anatomy of the pancreas. Now another thing. Sometimes, rarely though, there's a clinical embryological condition that the embryogenesis of pancreas is not normal. What happens? That there's a pancreatic tissue which binds around the duodenum. It winds, and once something winds like this, this is given the name as annular. What is annular? You know the annular ligament, isn't it? In a similar manner, we have got a term called as annular pancreas. And what is annular pancreas? Annular pancreas is once the pancreatic tissue, especially at the head end of the pancreas, just comes and winds around the duodenum. And it sometimes can obstruct the duodenum, and that is given the name as it is a congenital condition, annular pancreas. So remember, annular pancreas is one clinical condition, embryological condition, in which there is this end pancreatic tissue which comes in circles around the C of the duodenum, and neonate presence with vomiting again, and then this is to be taken in higher centers. It is to be taken very seriously. So it is a specialized procedure of operating on annular pancreas. So that is another important thing you have to remember as far as the relation of the head of the pancreas and abnormal development of the pancreatic tissue is concerned. Is it fine? Then, because I told you this pancreas, there are these superior mesenteric vessels, there is this abdominal aorta which forms the relation, the portal vein which forms the relation to different parts of the pancreas. I discussed with you. What is pancreatitis? Two things happen. In the lesser sac, behind the lesser sac, there is accumulation of the fluid. What? Accumulation of fluid. And that gives rise to swelling, which we give the name as pancreatic pseudocyst. Pancreatic pseudocyst. So what is a pancreatic pseudocyst? It is a swelling which is as a result of pancreatitis. And in here, the fluid collects behind the lesser sac. So pancreatic pseudocyst is a common entity after pancreatitis. Remember that. So this comes as far. Now, and sometimes once this pancreatic inflammation occurs, it damages the vessels in its surroundings. What? And these vessels, they just tend to give way. They just tend to give way. And what we call as inflammatory aneurysms. So these are aneurysms. The vessels dilate, okay? Because they loosen up. By virtue of that, it's very potentially dangerous, because a vessel can give way. Any big vessel which gives way can lead to a hypovolemic shock. So inflammatory pseudoaneurysms are quite common after episodes of pancreatitis, because they just dissolve anything which comes within their vicinity, and vessels can dilate. So this clinical condition is given the name as pseudo-inflammatory aneurysms, okay, or pseudoaneurysms, okay, which is both important. That's why we study pancreas from a surgical viewpoint with a lot of depth, okay. So this is something about the pancreas. Now, another important fact about the pancreas is that this pancreas, what should be surgeons a bit terrified with this thing, because touching pancreas itself incites inflammation. Now, relations. So you can see so many important things: abdominal aorta, the mesenteric vessels, the renal vessels, isn't it? Then the portal vein in the vicinity, and these are very congested once a surgeon does surgery. So you cannot go wrong, isn't it? So there's a high chance of damage to these structures, number one. Number second thing is the tail of the pancreas. The tail of the pancreas lies in relation to the spleen. Very important. So, कभी-कभी क्या होता है काम? Once this tail of the pancreas is involved, say in this sort of, the tail of the pancreas is involved, what happens? Say for example, a patient who is pancreas is normal, he is to be operated on spleen. I am in a situation where not the pancreas is normal. There is a problem with spleen. Should a surgeon be alarmed about this surgery? Yes, because pancreas is involved. He is not bothered much about spleen. He is bothered because the tail of the pancreas forms an important relation to the spleen. That's the importance of pancreas. Because usually surgeons tend to avoid pancreas. Very simple. It's as simple as that. So, but what can they do? They have to operate on the spleen. And what part of pancreas is associated with the in the liver, in the ligament? So that's a problem. So splenectomy by itself is not that big an issue, as an issue that the tail of the pancreas is related to the spleen. Got it? So that is why the tail of the pancreas, which forms an important relation with the hilum of the spleen, is a very, very important consideration once doing surgeries on the spleen or in the distal end at the tail of the pancreas. Because one does not want to fiddle with pancreas. That's important. So this is the importance of knowing something about the relations of the pancreas, the sea of the duodenum, the body, the annular pancreas, the pseudo-inflammatory aneurysms, the tail of the pancreas, as far as the splenic family is concerned. So that is another aspect. Now, as far as this pancreas is concerned, can you pause for that? You can suppose now, in addition to this, what I just told you, there are certain important points as well. Number one is that I just mentioned annular pancreas. And as far as the development of the pancreas is concerned, we'll be coming across in embryology that we'll come across the development that pancreas develops by virtue of two parts, ventral and dorsal pancreatic parts. Normally, embryogenesis goes on fine, but sometimes there is not a proper embryogenesis as far as the development and the fusion of the ventral and the dorsal pancreatic part is concerned. Okay? And in such cases, the pancreas remains a bit not like the way you see this pancreas. It is divided, and we give that condition the name as pancreas dualism. Okay? Pancreas dualism. So what is pancreas dualism or pancreas dualism? It is once the embryogenesis goes wrong with the development of the pancreas. So we have got a pancreas almost split up into two parts or maybe more than two parts. So that clinical entity is given the name as pancreas dualism. And then sometimes during embryogenesis we can be normally see there is this important thing that during embryogenesis we have got these tissues. There's the development of the tissues initially, and there will be abnormal implantation of a normal tissue at an abnormal site. Okay, so same can happen with the pancreatic tissue, that there will be the pancreatic tissue during embryogenesis, that it will just be there and it will migrate their abnormal location, and in an adult you will see that there will be small rest of ectopic tissue, maybe pancreatic, maybe uterine endometrium in case of females. So we call this the ectopic pancreas or ectopic rest of pancreatic tissue. And especially there is this one part which we will come across, Meckel's diverticulum. Usually in Meckel's diverticulum there might be an abnormal trace of a pancreatic tissue. So pancreatic tissue will be present abnormally in a location like Meckel's diverticulum, which we will be studying subsequently. And then there is one important tumor you have to remember in females, especially the ovaries of the females, and that is given the name as teratoma. What? Teratoma. And teratoma is one important tumor which arises from all the three germ layers. That means the mesoderm, endoderm and ectoderm all play a very important role. Okay? And in this tumor, which we give the name as dermoid cyst, ovarian tumor, there might be any tissue, thyroid, cartilage, bone, pancreatic, any sort of tissue. Why? Because all the three germ layers give their parts, because many things develop from endoderm, many things develop from mesoderm, many things develop from ectoderm. So this is one peculiar tumor in which you can have any sort of a tissue, and you can have pancreatic tissue, rarely though in case of dermoid cyst. So remember those two rare conditions in which you can have pancreatic tissue at an abnormal site as well. Now, as far as surgery is concerned, we have got this very unfortunately very deadly condition, cancer pancreas. It is one thing which I need to say has got a very poor prognosis on the whole. along with the adenocarcinoma gallbladder. These are two malignancies which are having a very, I would say, bit of a lesser 5-year survival rates. Adenocarcinoma pancreas and adenocarcinoma gallbladder. These are a bit of lethal malignancies. And unfortunately, many patients have got adenocarcinoma pancreas, and this is one clinical condition in which a patient just gets so many things. Pain in this region, in the pancreatic region, pain in the epigastrium, pain in the back, maybe jaundice, obstructive jaundice, and a lot of once it metastasis, a patient just deteriorates very rapidly. And there's this profound weight loss, fatigue, all those things. So adenocarcinoma pancreas is one important clinical condition which you should remember as a part of pancreas once the surgical concentrations are there. So pancreatitis, acute, chronic pancreatitis, pancreatic pseudocyst. I told you what it means, okay? Then I told you pancreas divisum. Then I told you annular pancreas, isn't it? So these are some of the things which are very important as far as the pancreas are concerned from a medical and a surgical perspective. So knowing the surgical anatomy of the pancreas, this will help you a long way. If you just remember these facts, these are very important.